This is Chapter 11, Behavioral Emergencies, and I think it's much more than behavioral. It's almost like a crisis intervention, psychological reaction to stress. It's a lot more than just behavioral emergencies. But to put it in a nutshell, when it falls under medicine like this, we think about it as recognition of a behavior that poses a risk to themselves or to others. So it's behavior that's not deemed acceptable by society. So we look at this, it's really a special patient population managing specific needs for somebody that could be a temporary situation or it could be a long-term problem that they have. And we're also going to look at recognizing and reporting abuse and neglect in here, especially with special needs patients. So introduction to this is in the care that you provide physically, you also give psychological support to each other as a team as well as your patients. So factors contributing to that behavioral changes can be anything that you come in contact with a patient. And in seeing size up in your patient assessment, remember that somebody who's suicidal doesn't mind to be being homicidal. Somebody that's got a crisis can't think rationally, and they may harm you when normally they wouldn't. So your own safety is going to be of utmost importance when you think about this. So think about that complete scene size up, starting from the dispatch information. What are we going to? What is the call? And what do I need to be thinking about as far as my own safety? What do I need to think about as far as the patient? Are they oriented? Are they in touch with reality? Is this something that, I'm not going to win this battle? I'm going to need more help with this. And as far as your assessment, big thing we want to do is rule out any obvious injuries that could be causing this. Could it be a low blood sugar problem that's causing them to be combative? Could it be a head injury that caused them to have slurred speech? Could it be a drug use or an absence of a drug that is causing this problem? In behavioral emergencies, we talk about crises with this. It's a person who exhibits abnormal, unacceptable behavior that can't be tolerated by people around them. And there are some medical conditions that can mimic this, so you have to kind of rule those out ahead of time, including, infection, just any kind of thing that could affect the brain, inadequate oxygen to the brain, head injuries, anything like that that could create this problem. If it's a psychiatric illness, is it already diagnosed and maybe they're not on their medications? Is it depression? Is it a panic problem? Is it a manic depressive? They're laughing one minute and crying the next. And is there anything that's compounding it? Maybe it's just alcohol or drug use that is causing this. Maybe it's a situational stress. They had a sudden death of a loved one, and it's just not something that they can deal with by themselves. So we look at the state of emotional upset or turmoil that could have an intrinsic problem or cause, whether it be depression or something psychological. Could be schizophrenia, and it could be an external source, loss of a loved one, loss of the job, a financial problem. And most of these situational crises are sudden and unexpected. They can't be handled. That's why they called you. That's why they activated EMS in here. Usually they last only a short time, and this is a true gift of somebody that can really come in here and de-escalate this situation. So there's 4 emotional phases to each situational crisis. Not everybody experiences every phase, and some last longer than others. Some people experience one or more. But the first one that we look at is that high anxiety. Just, you can't sleep, you can't work through something because you're so anxious. Usually the blood pressure will increase, and all of these signs and symptoms are associated with that higher blood pressure that you see in here. Emotional shock from a sudden illness, accident, a sudden death of a loved one. You may go to a call for something tragic that happened, and you have more than one patient just because of this emotional shock. And it's such that in our body we have this thing called a fight-flight syndrome. The sympathetic nervous system is wonderful. I've got on calls with partners, and as soon as we show up, This guy's trapped under a motorcycle, and as soon as we drive up, the motorcycle catches on fire. We're like, oh, look at that. Oh, he's on fire. And my partner jumps out, not much bigger than me, and she runs over and picks up the motorcycle and throws it off of him. So as a response to something that scares you, frightens you, we get a fight or a flight response. Either way, the body produces adrenaline, which gives us the ability to be bigger, better, stronger, faster. Or so bigger that our vessels rapidly dilate, and our vessels are the container that holds blood. They hold 5 to 6 liters of blood, but if they rapidly dilate it, now they can hold 9 liters of blood we don't own. So it makes us feel half full, and that's where people have this syncope, S-Y-N-C-O-P-E, syncope, or simple fainting, and signs of shock, like cool, clammy skin, rapid, weak pulse, just because of that emotional shock. As soon as they get horizontal, they feel better, and their vessels start tightening up again, but that's a sudden, unexpected thing. Another reaction could be that people refuse to accept the fact that the event has occurred. Allow the patient to express that denial, but this is where you give the bad news. I'm sorry, your spouse of 50 years has died. They died in their sleep, and they look at you like you have two heads. You are so wrong. Don't argue with them, but that's why we use the real words die, and I'm sorry, they have no pulse. Things that are very concrete, not like, I'm sorry they've passed. Well, what does that mean, they've passed? We use concrete words that they understand, but that's a normal first response, is that denial. I've called people at night to say, I'm sorry, your daughter's here in the ER, she's had an accident, and the parents are like, oh no, my daughter's in bed. I'm like, ma'am, I'll hold on the phone while you go check, but she's not in bed, she's here in the ER. First response is denial, not that. Second response could be anger. So this may follow denial, it may replace denial, they may not have denial at all, it may just vent their angry feelings towards you, and it's a sense of helplessness, and their natural response is just to be angry. We have to remain professional and calm. We just don't take any abuse. If you see that it's escalating, you need to retreat. Some people get real depressed. They start bargaining, but they experience grief, and that's a real feeling that people have. So, and it's okay to hug them. It's okay, they've experienced a loss. It's okay to say, I'm sorry for your loss. It's okay to stay there and say, is there anything I can do for you? That's what we do, that, we help take care of not only physical needs, but emotional needs too. So our role in this is step by step, check the patient. If there's nothing that you can do for the patient, if they've already died, then you turn your attention to the survivors, because that they may become your patients in here. So communicate with the patient, introduce yourself, ask their name and use it often. Tell them your name, make it personal. Be honest with them. If something's true, don't cover it up, don't sugarcoat it. I love this picture. She places herself at the patient's eye level. True empathy in here. That calm, steady voice that's reassuring, that is, gives patients some options, but not, A, B, it's A, B, or C. It's not, what do you want to do here? We give them choices like, do you want to go to the hospital with me, or do you want your friend to drive you? Either way, they're going to the hospital, right? We don't give them the C of, let's take you home, if that's not what they need. So, we let them communicate with us, you communicate with them, but those simple acts of kindness, that's what they're going to remember. Rephrase a person's own words and thoughts by repeating them back to them. I understand that you said this. Give them hope, but not false hope. Everything's going to be okay. That's not a cool thing to say. Sometimes we have to redirect. They're crying, and something needs to be done here. For instance, their husband of 50 years passed away, and the law enforcement's there. He died of natural causes, and they need you to decide on a funeral home, and they're just talk. I need to do this. Ma'am, did you decide on a funeral home that you want us to call? Do you want me to call your daughter? Redirect them on kind of what needs to be done. A lot of that helps alleviate their concerns. It's a list of things they need to do in their mind, and you're helping them step by step. Sometimes it's a crowd they don't need to be in, so by moving them to a more private location is good. Now, here's the real challenge as an EMR. You want to express concern and compassion for your fellow man that has experienced a tragedy, but it's real hard not to take that baggage home with you. And so the difference between the two, sympathy is I break down and cry with you and I feel your pain and I feel your loss, whereas empathy is you kind of imagine yourself in their position and you share this, but you're also able to stay a little bit detached and you're able to function, and that's a big thing. You don't break down and cry with them, but you understand, like, if I were in your situation, this is what I would want help with, and that helps them a lot. So it's one of the most helpful concepts that you can use. It's calm, it's caring, and unfortunately, sometimes it's matter of fact. These are the steps that we need to do. This is their emergency. It's not yours, and it's hard sometimes to separate yourself from that. Always let them know that you're there to help, whatever they need. Sometimes it can tie up your ambulance for a really long time if you get another call. Hopefully you have the resources that you can leave somebody there and staying with them because you have now a medical emergency you need to respond to. That calm, reassuring voice. Allow the patient to talk. Don't be judgmental about it. And assess them. They're now your patient. Crowd control can be a problem. Crowds can increase patients' anxiety. So sometimes you're in a family environment. They've got extended family came over maybe for a holiday or a birthday. And, it's 14 people in the room and they're all arguing. You need to take control of that scene. You control the scene. Turn down the TV. Turn off the radio. Take the phone away from the patient. They're sitting there talking on the phone, and you're like, do you need EMS or not? You control the scene. But sometimes it's to take those 14 people in the room and say, all y'all need to get out of here. You need to get out of this room so I can assess the patient. So crowd control is better to do earlier than late. Common occurrence in today's society is domestic abuse. It could be elder abuse, child abuse, and this doesn't have to be abuse in the form of physical injury. It could be abuse in the form of neglect or psychological injury or emotional problems. Spouse and domestic partner abuse also. So when you respond to a call like this, make sure you have your own safety as well as others. You do an effective assessment and treatment on here. And you try and separate the abuser from the abused to say, do you feel safe in this environment? It may be somebody that got punched in the face and they have a bruise. And you're like, wow, this lady does not need to go to the hospital by ambulance. But she doesn't need to stay there either. So if you don't feel safe in this area, you transport them and you report it. Biggest thing you can do is report it. So you look for physical signs and symptoms of domestic violence, like broken bones and cuts and bruises, especially old bruises. So a new bruise is red. It's like when you don't feel good and you put your head down on your forehead to hold your head up, and you raise your head up and you got a little circle redness there on your forehead. That looks like a new bruise. Then it starts turning purplish, and then as it starts to heal, it's yellow and green, those kind of colors. So new bruises on top of old bruises. Emotional symptoms, they're just withdrawn. They don't talk to you. They feel like they don't have any hope at all, real depressed. Maybe they had a suicide attempt, so ask them why they did that. Use of alcohol or drugs, and then again, that anxiety and hopelessness. So the abusers may be very paranoid or oversensitive, won't let you separate them from there because they're afraid they're going to tell on them. And that's, somebody that's really overbearing and I got to stay with them, and it may be that they're the abuser. Biggest thing, if you suspect abuse, you have to take care of yourself and the patient, and you have to report it. If you don't report suspected abuse, you get fined, you get penalized also. So not only is it a conscious effort to do, but it's also the law. Cycles of abuse. The abuser becomes angry and blames the victim. and then they explode. They become enraged, they lose control, the ability to think clearly, and they overreact. And they know they're doing it at the time, they just can't control it. And then they have that makeup phase. I wouldn't do this if I didn't drink. I wouldn't do this if I didn't just lose my job. They start making promises, making excuses, and then it's just a cycle. It continues on. So if you arrive on scene and somebody's violent like that, make an early attempt to get verbal and eye contact with that patient. Check for any other family member there, history of past violence. And if you see any yelling, verbal threatening, throwing things around, profanity, the best thing that you can do is make sure that you have an egress. You have a way out of that environment because you don't want to be cut off from that route of retreat. Have only one person talk to the patient, so not the two of you ganging up or 3 or 4. It's okay to be quiet in that situation. Secure your radios. Turn one of them off. Somebody's going to call law enforcement. Hey, we need some help here. We have an abusive spouse. We're trying to take care of the patient. Tell them what it is that you need so that you can get help as quickly as possible. I need to assess this patient, and the spouse is being violent. Violence against us. So that happens. You work either alone or in small numbers, first responding. You go at night. You go early in the morning, weekends, and in areas that may be high crime areas, in community settings. So you're in those environments that you wouldn't normally go to. You're going to walk into crime scenes. You're going to walk into incidents that involve gangs or high populace of people. Don't if you don't feel safe. If you get I don't get the warm and fuzzies here, back up and say, I'm staging in the area. You don't know how many times we responded to gunshot wounds and we parked 2 or 3 blocks away because we're the first emergency vehicle there, and that's not a cool thing. We want to make sure law enforcement is there. So make sure you stay safe all the time. Make sure you keep an escape route. You stay between whoever the violent person is and the door. You have an egress. You have a way to get out. The best way to avoid violence is not to be in that situation at all. Wait for help to arrive, and then think about your escape route. So it's not your role to handle an armed patient or an armed family member unless you're a law enforcement officer. So make sure hey, I'm sorry, man, I made a mistake. I'm going to go ahead and leave. My partner and I are leaving. We don't mean to be in your business, and make all the excuses and get out of there. Withdraw. If you can, if that armed person comes after you, there's a difference between cover and concealment. So concealment is something that they can't see you, but it may be a bush, it may be, a board or something like that. But bullets go through that. The ambulance is 1/4 inch plywood in the back. Bullets go through the back of the ambulance, so that's why we say we stage 2 or 3 blocks away at a minimum. But a true cover is something that's bulletproof. Difference between cover and concealment to get out of harm's way, to retreat. Medical and legal situations. So if somebody's emotionally disturbed, and they agree to be treated, that's easy. But when they don't agree to be treated, when they refuse your treatment, then you have to have reasonable belief that they would harm themselves or others. So you call law enforcement. And the big thing with that is you want to have at least 4 responders, 1 for each extremity of that patient. And you want law enforcement to be on your side. Yeah, this person's at risk to himself, so we need to make sure we move him and restrain him. Be careful how you restrain them. If you can put them on their side, that's fabulous. If you can put them on their back, make sure that they have an option if they should start to vomit. If you put them face down, and the natural tendency is to put that belt across their back and tighten it really tight, and then all of a sudden they can't breathe. That can create a situation called postural asphyxia, and people die in custody like that. So be real careful. Look at that individual and see if you think you can, hold them down, if you can restrain them. If you can't, make sure that you call for help. Think about your restraints. We want to use soft restraints, not anything that's going to cut into them like handcuffs or something like that. Make sure you document well. Make sure you document, because this is borderline kidnapping. You have to say this person was at risk to themselves. They attempted suicide. They had a medical condition and they weren't in their right mind. You be real careful with these. You have to document really well. Again, people who attempt suicide don't mind, taking you with them. So more than likely, if they fail at that attempt, they're going to try it again. So it's not like, I didn't mean to do this. I'm okay now. No, they have to go. They have to go seek treatment. You're going to find them dead the next morning if you don't. So kind of think about that. We do a lot of supportive things. If they've lacerated their arms or anything, we dress and bandage. We treat the patient. Don't judge them. You haven't walked in their shoes. You don't know what they've had to deal with. And whatever it is, if they tell you, you're like, well, that's not such a big deal, but to them it is. So don't say anything that sounds judgmental of this. PTSD, post-traumatic stress disorder, could be from somebody that was in the military. Could be somebody that worked in law enforcement, fire, EMS, and they have flashbacks, sleep disturbances, maybe some guilt. So even with us in EMS, we can experience this. And we talked about this in our wellness, but one of the best things that you can do is exercise. It helps get the byproduct of the chemicals from stress out of your body faster, but don't be afraid to ask for help. This really bothered me because I knew this family and they all burned to death, and I'm really upset. Don't be afraid to ask for help in something like this. You could respond to a call for sexual assault, and psychological aspects are just as important as the physical part of this. So if a woman was sexually assaulted, it's best to have a female responder take care of that. If a male was sexually assaulted, it kind of depends on the situation, because for the most part, a male assaulted the male, and he may not feel that comfortable with a male taking care of him. But your first priority is the well-being of that patient. Injuries that they may have, for the most part, physical injuries you have to treat, but you have to also be very careful taking care of the crime scene, because it is a crime. So if you have to remove clothing, do so only if necessary. Don't cut through anything that could have any evidence on it, like through the crotch of the panties, or through a stab wound or a bullet wound. Cut around those. This is real hard to do, especially in a small community. But especially if a female urinates, she's going to lose a lot of the semen, what they can get DNA from. So as much as you can say, well, if you don't really have to go, can you wait till we can do the sexual assault exam? And that's going to be done in a hospital. So, and if they do have to go, make sure you collect that and turn it over to law enforcement, because then that's going to be chain of evidence in there. Don't ask a woman, well, is this what you were wearing when this happened? Then it makes it sound judgmental, like, oh, I asked for it. If I hadn't been wearing this, this wouldn't happen. And again, empathy goes a long way in here. But it is a crime scene, so your documentation is really important in gathering all the information. Death and dying. So time to time, you're going to encounter somebody that is either in the process of dying or has already died. It may be natural causes. It may be accidental. It may be intentional. It may be homicide. So if that patient is dying, they have terminal issues or whatever, some people are afraid of dying. Some have completely accepted it. They come in all walks of life, but your personal feelings about death have to be addressed. You have to think about how I feel about this, because you can't put your own morals and values into somebody else. Somebody's got 98 years old and terminal cancer, and they're fighting to stay alive. You're like, man, this guy should be euthanized. No, that's not for you to say. Or if somebody says, I've got terminal cancer, I just want to die, and you're against, you're more pro-life, against euthanasia, you can't throw that out. You have to kind of think about where they're at with this.